দেখো তো শোনা, হ্যালো, শোনা যায়? ফোন দাও না, ওদের সমস্যা। Can we see the? Can we start the live case? Having some issues with the transmission, so it should be resolved by now. Let's see. So we have an interesting case line, and Dr. Dagubati, Ramesh Dagubati, will be performing the case. Actually, it's already started, but we can't seem to be seeing it. They can start transmitting. কিছু দেখতে পারতেছি না আমরা। কি বললো? হচ্ছে না? If they can't fix it, we can maybe go to a master CD class. এটা অফলাইনে করে ফেলতে হবে। না, আমাদের নিজেদের কন্ট্রোল রুম, ওই যে আমাদের কানেকশন, আমাদের বেশ অনেক টাকা দিয়ে আমরা করছি কানেকশন ফাইবার অপটিক দিয়ে, বাট মানে ইমিডিয়েট কস্ট অনেক লাগবে ফোনে আমি ইনস্টলেশন করতে পারি। হ্যাঁ, আমরা লাইভ কেস সবার জন্য করে দিই, আমাদের এক্সট্রা ওনাদের সঙ্গে লোক টোক লাগে না, আমরাই করি। ফাইবার অপটিক কেবল আমরা করে দিচ্ছি যে একটা কিছু ইঞ্জিনিয়ার ছিল টপি, যে আগে লাইট কেস করতো, ওই করে দিচ্ছিলাম আগে মেডিকেল সিভিল আগে আমরা সব কনফারেন্স ওই কানেকশন দিকে পারলাম ফার্স্ট একটা বছর পর দিয়ে So if there's an issue with the live case, we can start our CD presentation. So those of our panel who are here, announce the rest of the panel. Let us start the CD presentation. If by then the live case can be seen, we'll see it. Otherwise, we'll see it or we'll see it up. Huh? They've started showing now. Can you hear us? If they can't hear us, if they can't hear us, no use doing a live case, right? So just call them. If না অনেক সময় লাগলে তাহলে এটা বাদ, এখন তাহলে আমরা যে স্যাররা 4 জন আছেন আরো 4 জনকে উঠে সিডি করলে হয়, এটা ফোন করে বলো যে এটা ঠিক হলে পরে আমরা দেখব। জাস্ট শেষ করে দিতে কেস আমরা জাস্ট লাইভ ইন বক্সের মতো দেখে ফেলবো।
হয়ে গেছে।
হয়ে গেছে, ঠিক হয়েছে। এই রাটা কই থেকে কথা বলো?
আমি ক্যাটলাবে ম্যাডাম।
আচ্ছা তাহলে তো ঠিক হয়ে গেছে, তুমি কথা তো তোমার কথা শুনি এখন আমরা। হ্যাঁ তাহলে বলো, তাহলে আমরা শুরু করি তাহলে। Can we start?
Yes. Can you hear us?
Hello. Hello. Now, can someone present the case for us?
Yeah, sure. Okay.
Yes.
So,
Can
can you hear us, Dr. Malik?
Yes, absolutely. We can hear you.
Can-
There's
okay.
Ashok there, and
Yes,
we can see Ramesh. We can see Moshed. So,
Can you hear me?
Yes, we can hear you now.
Yeah. So, ma'am, this is a patient, male patient, hypertensive, diabetic, dyslipidemic, and a smoker as well, having chronic stable angina. Angiogram done before and 5 days back, there is severe TBD. So in the 5 days back, there was I think there is angiographic views in APST area.
Yes, we see a very diffusely diseased RCA.
So this is the today's view. But before, this is the stage PCI we are doing on the LAD. Before there was a lesion in the distal RCA that was tackled with DCB. And now today's angiographic view, it's look good after 7 days.
So will you care to show us that result?
So that
Okay. The previous angiogram, I don't think we have.
that-
But he had a mid circumflex or mid to distal circumflex 99% lesion, which was probably corresponding to his posterior MI that was treated with a stent in the circumflex. And then the distal right also was treated with a PTCA. So then this is a staged PCI for the LAD, and they attempted actually a PCI at that time with a wire, and a 1.25 balloon was able to cross, but no more than a 1.25 balloon. So then obviously we needed to address the LAD, and since he has a diffuse disease in the RCA and only calcified lesion in the LAD, we can think about two options. One is bypass surgery. The other one is a complete revascularization with PCI. So that's probably what one of the discussion points would be. As you can
So
see now on the slides, he had a CCS class 3, EF is preserved, and but on the angio, this is there's an angio which actually shows that there is a tram track appearance of the mid LAD completely, and significant lesions in the LAD that actually which is also tortuous vessel. So I saw the session on the calcified lesions. How would you approach? Maybe you can ask the panelists and let us know.
Panelists, the comments from the panelists.
Yeah, this really is a tough case, the triple vessel disease and diffuse calcified lesion. I think that as the patient is in the cath lab, so there's no question about the surgery. So right side, I think they said that they have done that drug-eluting balloon angioplasty for the right. Now, as that time LAD was not possible to do anything, so it was been posted today for the stage PCI. Looking at the LAD, it almost 2/3 of its length is disease. So as usual, I think you can image it first. Then if the calcium is too much, then you can use the rotablation, and then the stent with 2 stents from the mid distal LAD to up to the proximal LAD. That should be my proposition.
Thank you.
Hello.
Yes.
Can
Yes,
I-
sir. Yes, sir.
Hello. Actually, this was my patient. Actually, so let me describe more. This patient actually admitted with chronic stable angina, and he has severe TBD. And actually, this patient has refused CABG by any means. So we did RCA because there was distal occlusion of the RCA. When we opened up the RCA, it was a very small vessel. So we thought there is no point of implanting a stent. So we did a DCV there, and we opened the ILCA. Then when we started doing LAD, We crossed the lesion, but not a 1.25 billion was not crossing. So we planned for rota, but the patient was not agreeing actually. Patient said, okay, let me think whether I should do or not. Then patient, okay, so we'll do it later on. Then the patient agreed, yeah, I am ready to do anything you want to do. So this time today, he was ready for a rota, whatever is needed, I don't know. So this was a stress PCI for the LAD.
Right.
And my thought at that time was rota is needed. Without rota, I cannot proceed. I don't know what you are doing there now.
So what have you done up till now?
Okay. So we tried initially just to see what happens if you can cross with a run-through wire and a fine cross. And the fine cross wouldn't go beyond that lesion in the mid LAD. And so
Can you show that fine cross not crossing?
Yeah. Go back.
Because a lot of tortuosity and calcium.
Go back.
Go back.
Back one more. So with that, yeah, go forward now, please. And yeah. So when the fine cross wasn't crossing, we knew that it is not going to be done without anything else other than an atherectomy. So we did not even attempt to cross it with an IVUS because, as you can see, it is very heavily calcified. Go next, please. Okay. And go next, one more.
Next. So this is the fine cross.
Okay. It's not next one, please.
So you see catheter was moving back when we push the fine cross.
Yeah. So this is a 1.1 to 1.2 millimeters, and so now we removed the rota. Removed the run-through wire and going with the rota floppy, and that was not obviously well successful. So we removed that. Next, please, because of the tortuosity. Then we went with a caravel and run-through again. Okay. So next, please. We were able to place the caravel run-through wire distally and advance the caravel. Next, please. And then we exchanged that with rota floppy, and then we started doing rotational atherectomy here at 160,000 RPM. And we did completely, I think, 5 to 6 runs, and we were able to cross the lesion. Next, please. You can show the next. Okay. Keep going. It's a long lesion, in fact, and heavily calcified.
And that's what you usually see, very diffusely diseased, narrow caliber vessels. The smaller size balloon doesn't go. And in these patients, you end up doing a atherectomy.
Right. We also thought the other option is shock wave. I mean, obviously, for shock wave to work, we need to have at least a 2.5 balloon cross. And even after rota, we tried with the
2.5.
We tried with NC 2.75. It wouldn't cross, and so now we still might have to do. Fluoro, say that please. Might have still to do a rota shock or something. So we are going to prepare the vessel now, and then we'll do an OCT. If that's what type of imaging would you recommend? You can go on.
Whatever imaging you are comfortable with, I suppose.
No, right. Yes, I think that's the best answer, because in case if you want to see very clearly, we want to make sure that OCT probably may be better, but IVUS is also not
Yes,
bad
I'm
option.
going up.
So we are using a new 2.5 into 15 millimeter balloon, compliant balloon right now, and we're preparing the bed a little bit more. So you can see that it is expanding quite well. Go up again.
So maybe you will not be needing an IVL. And doing an IVL to this entire diffuse disease might be very time consuming.
Negative.
Yes. Yeah. So this is a 4-man IVUS where you can see if you can advance a balloon.
Here we can
that means it's easy,
up.
but you still can go up one more time.
One more time.
Yeah.
18.
Any comments from our panelists on?
Thank you, madam. As you have seen, there is a very diffuse calcific lesions involving the almost the LED ostium to the distal mid segment of the LED. Though in this situation, should we consider the wiring the diagonal also? There is a big diagonal I have seen here.
So the question to you is, will you contemplate wiring the diagonal at this point? You've done your rota, you've got a large size diagonal, you want to wire it.
I didn't think it required because this is definitely the lesion is beyond the diagonal, and still obviously there is a osteal diagonal, maybe 50% lesion. We can take a picture and see how it is. And
Giving night to
yeah.
So what are his creatinines?
Creatinine is normal, quite normal.
1.1.
LV function is PGAP, 80% ejection
We
fraction.
can, but we can take an IVUS. It's okay to do IVUS. Yeah.
So, no angio?
Yeah.
Yeah.
And actually, after the rota, he developed a spasm. So that can happen with which was relieved with nitroglycerin easily. You know. So, how many people recommend NC balloon versus cutting balloon after rota to prepare the vessels much better?
So
Do we always
I
have to
think-
use a cutting balloon? You know?
I think in this situation, I would like to use another wire to stabilize the guide catheter much better, track the device easily, and also dilate the whole length with 1:1 ratio balloon, preferably a small balloon. So if there is any remain calcification lesion, that can be well dilated, because the bar was, I think it was 1.5. So if you can dilate with a 2.5 millimeter distally and proximally with 3 millimeter, it will be enough to expand. And after that, the image definitely will help. What to do
Yes.
next?
Right.
So regarding
Yes.
the sizing of the stent.
Yes. Is it going?
Can see the IVUS. Can you IVUS screen? Okay. Can you? We'll go to.
IVUS image. IVUS image, please, Rana.
Even the
So your
IVUS.
IVUS went very easily.
But it got stuck in
It's stuck here.
in that mid portion. We still probably have to
So this is the place where the
at the
Fine-
curvature.
fine- fine
Can
cur-
you see the angio as well? Or no? So
Fine
it got
course was
stuck
stuck here.
in the mid portion,
there is
and there is still a 180-degree arc of calcium. So I think as you can see, it is still needs a little bit more preparation. And there is definitely a circumferential 360-degree arc of calcium with the right there.
yes.
And
So do you plan to take a scoring balloon or a cutting balloon now?
yes, because of that, this is why I asked the question. If there is a circumferential calcium, I would definitely choose a cutting balloon. And so let's take one. Hold on.
Sorry.
Yeah, sorry. A 2
I
point.
believe we have Wolverine on the shelf as well as quite a few scoring balloons. So
Yeah.
whatever you prefer.
Yeah, we can take a Wolverine or a. Yeah, okay, we'll take that. Scoring
Scoring,
balloon
we
is
can
good.
take.
Yeah. So Angio Scout is a scoring balloon. I think here we have a different one. By the way, Dr. Malik, you have a fantastic team. With me is Dr. Datta, of course, and Lippy and Musara.
Yeah, thank
And
you.
Musharraf.
So
Murshid,
as we like to say that it's the entire team that does the work collectively.
Yes, absolutely.
And that's how work becomes
Sorry.
a lot of fun as well.
Right, yes, yeah. So they are very knowledgeable. That's the most important, to have a good team.
I have a question.
So
We have-
as
we
you
have-
see
we have
that
only-
I think these
we have only
lesions
3 center
heavily
rota
calcified
in Bangladesh.
lesions, you
So,
should never,
is it possible
Dr.
to
Ghosh's
stiffer wire
case, as you saw,
and
for
two
the
stiffer
nice
wire,
case
support wire,
where you
that
need to
is
make sure that the
Hollister or
stent
any,
is
wire?
deployed only after preparing the vessel. If not,
Yeah, and giving the
we'll have a
NC
severe
balloon
rota regrets
to
of
cutting the
such patients.
calcium without the IVUS rota, sir? Is it possible?
Okay, you can
Yes.
go.
I said that most of our center don't have any facilities for rota or IVUS. So what we'll do, almost 95% cases you can
18.
deal with without this tool, except one situation where the balloon does not cross, better not to touch without rota. Other cases, put 2 wire, get a very good support, if necessary, get Zilla. Then the 1:1 size balloon, preferably small balloon, and dilate that particular spotted area for at least 30 seconds. If or yeah, as much as the patient can tolerate, because as long as you push it, there'll be slight uh, displacement of
10,
micro displacement of the calcium, and
12,
ultimately the room will be.
12.
And once you are happy, yes, there is no dog bone. By seeing the spinning of the
Negative. Yes,
of
negative.
the CR, there is no dog
Yeah,
bone. You are
yes.
sure that the stent will expand
I'm
nicely.
going up.
Right.
Balloon, cutting balloon or open
12,
balloon, which is better?
Expansive.
14.
Because this balloon can go non-compliant balloon can go up to 20, even 24.
Can you go a bit
But scope balloon will not go more than
low?
14.
A bit low. Yeah.
So there is a
No,
chance
no,
of rupture.
Just pull back.
Okay.
24. Yeah.
Yeah.
But I think so in this case it's a little different because balloon is not going
A bit pull
down.
back and that.
So it has to be started with rotor, no doubt.
Yes, yes.
This
Right.
is this is
Yes,
this
okay.
is this is okay. I think so. And now the vigorous post dilatation by the
12.
either scoring
Okay.
or cutting balloon may be the best option for this
12
case.
is okay.
And there is a calcium is an
14.
240 degree calcium actually, and calcium is also thick.
Okay.
Yeah, so I think when you don't have an option, either rota or an IVL has to be
Yes.
done. And if the balloon doesn't cross, IVL is out of the question, right? You need to.
12.
IVL balloon is a little bit bulkier
14.
than a 2.5 non-compliant
18.
balloon.
That is exactly that is
18.
Good. Yeah, down.
Yes.
So for all of us, those of us who are starting intervention, just remember that for your
Like
vast
that.
majority of cases,
Yeah,
what
go.
Professor Mominuzaman has suggested will work. But for a small proportion of cases,
18.
you might get stuck. Your balloon, your wire has gone down, but nothing else is going down. And in those maybe 1 to 3% of cases, you will need to do rota. Like, I mean, rota
Yes.
is not something that you would need to do every day, but when it is required, it is required. Like today, they were unable to pass any
Yes.
balloon, and so they had to do rota.
So I would suggest actually looking at your experience, Dr. Malik. I think if somebody does not have
No.
experience, they should bring their patients and do it with an experienced operator. So that's my recommendation. So as to
What?
learn, yes, please. To learn how to do rota, so that once you do about 5
Sure.
to 10 patients, maybe you can do them on your own. Yes.
Yes.
I think that's a great suggestion. So if you have very difficult cases, you can
Right.
always
Yes.
choose a mentor. Like you can go to Professor Mominuzaman. I'm sure he's going to be happy to help you out. Any one of us would be happy to help you out. And so start with simple cases and sort of build up your experience as you go along the way. And in most cases, you will not be needing rota. Maybe.
Yeah, that's even the amount of atherectomy that is done in the United States. It's about 5 to 10% of the patients, and but as we always recognize, everybody is scared of rota. The moment you say rota, people are always thinking about the worst complications such as a perforation. You can take a picture.
No, just sorry. Sir.
And so IVL is picking up a little bit.
No.
It's because it is a very diffuse, long disease.
Listen.
How long we will stand? How we decide? I want to know.
Yeah,
Keeping in mind to less chance of re-stenosis.
So, Dr. Dugabati wants to comment on that. So, the question was that it's a very long, diffuse disease. How does he get to decide from where to stand
yeah.
and how long?
We need to base it on IVUS, of course, and that's the only way. And probably here we have a minimum of 48 millimeter or even longer balloon is required, longer stent is required. We initially thought 48, but probably longer than that.
Is there any chance of combining stent with DCV?
Normal to normal.
Bring DCV
And
the
also
distal
look for any bend. Try to avoid or cross the bend. Otherwise, there will be dissection of the bend. So you may need another stent to cover this. Here, in this case, there is a bend between the small diagonal and the septal. So you'll have to cross the last diagonal, I think.
No. It is too much distally, that's right. But here you will not find any normal to normal, basically, I'm sure that. There will be some plaque, either distally or proximally. So that's why The normal to normal, it is not possible here. What do you think?
You're right. We'll just
Yes, sir.
See with Dr. Rahman. We'll see with Ivers again. One more time. I just want to use a nice non-compliant balloon, and the balloon went in very easily, so I even pushed it all the way to the distal one. So this is a non-compliant balloon. So just want to make sure. Okay, a little bit beyond that. That's where I want to end my stent. Okay, go up, please. So this is how much distally I want the marker of the stent. Okay. Good. So I'm going to prep one more time. That's good. And down.
Down.
Okay. Up. The balloon
16.
expansion can be seen very well, right?
16,
So what pressure are you going up to?
18,
14 to 18 in between that. Distally we went up to 14, and
And
now
what's the size of the NC balloon?
2.75,
2.75 into 12, right?
12,
Yes.
Right.
That's good.
18.
So this is a very long diffuse disease. Why did you choose 12? Could you not have chosen a bit longer balloon than your
18.
You're right, ma'am. I think it could be done in an NC balloon. So we thought it's better to leave with a 2.75, 2.5 or 2.75 valve. I feel that it is better sometimes to choose shorter stents, shorter balloons, so that the radial strength will be better.
Yes. Negative.
I mean, that's my own thing, but I don't know whether we can prove or disprove that point. Okay.
Okay, we can go.
I agree with you. I think
18.
with a short balloon you get better.
Yes.
All right. We'll just take one quick IVUS one more time. And
IBIS.
we had some technical difficulties before. Sorry for that. And I'm sure you've been eagerly waiting.
So if it's a very diffuse disease, and maybe is there an option that for the larger part you stent, and for the rest of the you might consider DCB? Now,
Yes,
some DCBs become suddenly very topical after
Yes.
Professor Antonio Colombo left us. Everyone's talking about DCB.
Absolutely.
Yeah. So maybe DCB could be an option for, instead of jailing the whole vessel, we just do stenting of the tightest proximal part.
IBIS, please. IBIS, please, Rana.
Okay, so I think Dr. Raman was saying earlier, this is a normal vessel here, as you can see. I mean, not completely normal, but there is at least not much of calcium. And so this is where...
So you've got a bit of calcium here, right?
Right, yeah. So I'm going to stent beyond that. And it looks like at least 2.75 vessel.
So calcium is cracked here.
And
Here you've got,
Till now, there is.
yeah, here you've got quite a bit of calcium.
Yes.
right. But the area looks good, right, Doctor? So, any recommendations on
Proximal.
Yeah, this is the proximal, and there's a lot of calcium. I mean, there's some cracks here, and
Madam, I have a question here. Should you consider stent from LM to LED or only the LED? Should you consider stent from the LM to LED or only the LED?
So we can see the
As
ostium
because
of the
there is
LED.
lesions involving the ostium
Have you
of the
seen
LED.
the ostium of the LED? So the question is, do you stent from left main to LED and go down, or do you stent? I mean, it depends on what the ostia looks like in the LED, right?
yeah. So go
This is
back
the
again and go live again, please. Okay. So this is the ostium of the LED, and I think ostium of the LED is okay. There is proximal LED that has
Proximal
a
LED,
disease.
yes.
Right. Yeah.
Yeah, this is the
So
proximal LED.
we are planning to stent from this is the proximal
Okay.
edge of the stent where we want it to be. So I'm
If we
just-
consider the lip main to LED, should we consider another wire in the L6?
Yes,
Yes.
absolutely, sir. Yeah. For me, LCX is different compared to than diagonal. I think there some people feel that they are the same, but this left circumflex is much bigger, and I would definitely protect the side branch LCX here. So I actually feel that this patient would still benefit from a shock wave, even though it can only deliver 8 treatments, and at least the calcium will still be much better fractured. And how many people feel that the stent will be able to get a better result versus a shock wave now?
Do you
No,
like to
that
take
is a very
LCXY?
difficult situation.
LCXY,
And
do you like to give?
do you
No.
think
No.
there is a thicker calcium and circumferential
Never.
calcium, and the calcium was not cracked? Do you think it is better to do the IVL in some part of the coronary artery in this case?
Yes, that's what I am saying, Dr.
I am thinking so.
Come down on the calcium, you can show. I think that there was some distally. There was
So if, I mean, definitely an IVL is an option, but if cost comes into consideration, would you consider trying with a scoring balloon now?
we did the scoring balloon already.
Oh, this was, you're already used
Yeah,
a
yeah,
scoring
yeah.
balloon.
So we used a scoring balloon,
Then
so
NC
and
275
a
NC.
non-compliant balloon as well.
Okay, so you've used a non-compliant balloon, you've used a scoring balloon,
Yes, ma'am.
and still you have this huge amount of calcium left.
Right.
I suppose it's a valid option now to use an IVL if you want to.
Yes, I think so.
Madam,
So,
actually, we started
and
with
we have a 3O IVL.
2.5 compliant balloon, then 2.5 scoring balloon, then 2.75 non-compliant balloon.
3O scoring balloon.
3O
10.
scoring balloon.
So Tom has a question.
Yeah,
Yes, Tom.
well, a comment really. I mean, we kind of expect the IVUS
So
to show
what we
calcium.
call as rota shock, I think has
So-
been tried before. Some people tried it just to show that.
So
we
Tom
can
had
do
a
it.
comment,
Yeah.
Dr. Dugabati.
Ramesh,
ma'am.
so
Yeah, go
I think
ahead, Tom.
some really interesting features from the IVUS. So the first question being left main or proximal LAD, and as you say, the lumen area in the proximal LAD is reasonable, but the plaque burden is high, and so there's a trade-off. Either you accept that you lumenly size at the ostium of the LAD, and you may get dissection, which may then require
We
you to go
cannot
back
hear
into
you.
the left main.
Yeah, Dr. Malik will repeat. So we couldn't hear.
Sorry, you can hear this microphone.
Yes, right. We can hear you now.
So there are a couple of interesting issues. So the calcium, you're right. It's not that surprising that there's calcium. You kind of expect that with what you've done, but you've got that freeze frame that we've got there has actually got a reasonable area,
Right.
and it's a horseshoe. It's not concentric, and so your balloon will expand out into the more elastic area. And I would possibly avoid using IVL here and expect to get a very reasonable stent area. Working within the NHS, where we're always trying to save money as well. But I mean, equally, I see you're taking it, and you will get better fracture. But I think the interpretation is always very different from one person to the next, which is why this kind of case is so important to share. But the other issue, sorry, that I was talking that you couldn't hear was about that issue about landing to the ostium of the LAD or back into the left main. And again, the lumen area is good, but the plaque burden is high, and so there's a trade-off where I probably would elect, like you will, to land in the ostium of the LAD, but expect that if there's a dissection, you might stent left main to LAD as a second stent.
If cost is not a concern, I'm sure everybody will be using IVL, right? We need to make sure that the cost can come down, and how will it come down is also a difficult issue, you know.
So the issue that Tom has raised is that in many parts, it's not like a 360 degrees of calcium. So where you have only like horseshoe-shaped calcium, the question is, will your IVL do a decent job there?
Yeah, that's correct.
Or, and
Yes.
for the matter, your balloon also would go towards the fibrotic, elastic part rather than the calcified part, right?
Yes.
So-
I've seen actually IVL do a great job, you know. So post rota, in case if it is still in this way, two options. One, we can use another rota birth, which is going to be again increasing the cost as well, and otherwise we can use a shock wave. You know.
So from an economic point of view, stepping up your burr would be a lot cheaper.
Yes. But thing is that the already the LED lumen is already open. So I am not sure how far increasing the bar you will tackle the calcium like that. It is an IVL that will be suitable in this case.
Actually, IVL can help the proximal part where there is a circumferential part. But distally, there is a nodular area and horseshoe shaped area. Not sure about the use of IVL distally. Rather, if Fazila said that if the upsize the bar 1.75, then both the nodule and part of the proximal calcification could be tackled better than IVL.
So just connect it to the.
But Ramesh,
Yes, sir.
already you have dilated 2.75 balloon.
Yes.
And lumen is already opened up. Do you think that if you increase the bar, how much bar will be increases to tackle this calcium?
Yeah, I'm limited. I can't increase the burr size because I went with the 6-inch catheter and radial. So if at all I could go with the 1.75 burr, that will also be very tight.
No,
And so unfortunately, that is an option if you had a 7-inch and but I wouldn't go with a 2.0 or a burr. So come with me.
Yes.
Can you bring that machine this side? Put it on the rotor side.
What's your plan right now then?
We are going with IDL, ma'am. Okay, so IVL balloon is advanced to the place where I want it to be. And so as you can see that now we go up to, it's kind of,
A really nice tip from my colleague Peter O'Kane in
Go
the
up to
UK is
4
to do a stent boost at this point, and you
Stent
actually
boost.
then get to see the electrodes
boost,
and the
yes.
relationship to the calcium. It's a really nice way of visualizing where the catheter is. So it's what you do it after.
Okay.
There'll be multiple runs.
okay. Yeah, we'll do one right after this. We went up to 4 atmospheres, as you can see. And okay, go ahead. Delivering? It's not delivering. No, you press this one.
Oh, yes. You can press
So
it.
after being on the 4 atmospheres, you just have to, where's the button here? Okay. So there's a button here, advance up to 4, and as you can see, and increase. And we are delivering now. So sometimes you can see that actually at 4 atmospheres, if it did not yield, it is going to yield well. So now go up to 6.
6.
Okay. And come down.
So what size balloon is that, Ramesh? 3 or
3 or
2.5?
12. Yeah. 3 or 12. Yeah. Down.
Down. Down.
So this part I'm not so much concerned. I think more concerned about a
That bending
little
part.
bit right here. So go up again to 4. I mean, actually, in fact, if people see, you can see that it has not expanded here.
Yeah.
And so now you can leave that
Yes.
one and go ahead and.
So just for those not
Yes.
familiar, so you're at 4 atmospheres and now you're deploying a train of 10 shocks,
Right.
and then you increase the balloon up to 6 atmospheres prior to then withdrawal of the balloon or
I'm going
deflation
to
of the balloon.
6.
Yeah.
6.
Yeah.
Yes. Button press.
No. Okay, now deflate.
Do you want to,
Deflate, yeah.
could you just cone in there and do a stent boost once
Yeah.
the balloon's down? Because that
Okay.
might be quite instructive.
Okay. Can you do a stent boost here, please? I pushed it in a little bit actually. So go ahead and. Fluoro?
Sir. Fluoro release.
Fluoro
the
release.
fluoro.
Yeah.
Yes. No fluoro. Yes. Cine? Yes. So this is the.
Can you see that? That's a beautiful suggestion, Tom.
Yeah, you can. So you can see the 2 electrodes inside the balloon marker.
Yes.
and then you can see the tramline calcification either side. With a true stent booster, sort of prolonged 3-second acquisition and the stent boosting, you get an even clearer definition of the calcium.
Yeah. So probably I need to go a little bit more in.
Yeah, but just from an educational point of view, it's important to understand that obviously the energy is elicited in an arc from each of those two electrodes, and moving the catheter just a millimeter or two up and down the vessel at the area where you see the greatest restriction will further impact on the chance of calcium fracture.
Given? Yes. We are taking another boost.
You wanted 3 seconds. Yeah, you can see that. That's a very good picture.
Actually, we are running out of time.
Yes.
This was a 40-minute session. We've already crossed 50 minutes.
I'm so sorry.
So maybe after this, we can have a look with the IVUS and see how the calcium has cracked.
Yeah.
And then we can go offline, and you can maybe show us the final results while the master CD is being presented.
Yes.
Because this was a great learning case, actually, right?
Yeah, and you can see
calcium and everything. Yes.
Yeah.
So I mean, once you've done IVL and an IVUS run, the next step would be to put in your stents, which you can do offline, I suppose.
Sure. And you could see that even the third delivery of the IVL showed that at 4 atmospheres, the balloon expanded much better than before. So we'll do that, and we can show you offline the IVUS and the final pictures, if you don't mind. Okay.
We're good with that.
Yeah.
So I think we'll say bye to you now, and you can finish the case, and we'll start our master CD session now. And towards the end of the CD session, I hope that you can show us the rest of the case.
Yes, ma'am.
As
Sounds
you've
good.
done it, right? Okay, great.
Sounds
Thank
good.
you, and a big hand. You showed us a lot of, and that this was a great learning experience. Thank you.
Thank you. Thank you. We go up to 4. We have 5 more treatments.
Okay, now we are going to have our last session of NHF CCD 2022. This is the Master CD session. So we'd like to request to join in the Master CD session Professor Fazilatunisa Malik, Professor Afzalur Rahman, Dr. Mominuz Zaman, and also requesting Dr. Mizanur Rahman and Dr. Manoj Chopra. Please do join the Master CD session. And asking Fazila Malik to invite our presenters. Dr. Manoj Chopra, please do join.
So our first presenter today is Professor Dhiman Bunik from NHFH NRI, and you all have 7 minutes to present. Dr. Dhiman, Professor Dhiman Bunik. Huh? And after 7 minutes, we'll have 3 to 4 minutes of discussion, right? So with each case, we'll finish the discussion and that.
Respected teachers, colleagues and friends, moderators and chairpersons. Today, I will present a case, the rocky road that became a gentle breeze. I have no conflict or interest. This is an Mr. X, octogenarian, male, diabetic, hypertensive, ex-smoker with dyslipidemic. He has comorbidities of COPD and mild CKD. Effort angina was, he has the CCS class 4. He was, T inversion was present in 2-3 ABF, B4 to B6, and ST segment was elevated in AVR. He was coming repeatedly to our outdoor, and we planned for doing an angiogram and advice for angiogram and advice in a normal ward in our hospital. And the day before their angiogram, he had a severe chest pain and he was shifted to a high density ward. So we planned for the angiogram on the next day, and he has a regional wall motion abnormality with ejection fraction 52%. This was the angiogram reveals. We did the RCA first. RCA reveals about 50 to 60% stenosis in the proximal segment. And on the then I went to the left side. You can easily see that there is a calcified vessel, and the distal left main is about 95 to 99% stenosis at the distal left main, involving the origin of the LCX and LAD. Ostial LAD is about 99% stenosis with an eccentric plug of calcium. Having LCX is 50 to 65% stenosis at its origin. And the distal vessel is almost normal. We did the syntax score. Syntax was about 28. We did the syntax 2. Syntax 2, as the patient has a mild CKD, octogenarian, this treatment recommended for PCI. We kept the patient in the post-CC ward, and at that, in the meantime, the patient developed severe chest pain, and the BP was falling. So we talked to the party and decided to do the PTC of this patient. Issues were severe chest pain with hemodynamic instability. The age was 80 years. He has two comorbidities with COPD and CKD. The only positive thing was that his ejection fraction was normal. So we planned for in PCI, preferably single stent strategy, maybe turnover to a double stent strategy, covering the single stent strategy with covering the left main to L6 first, as the patient having chest pain with reduction of blood pressure. So we taken 3.5 extra backup catheter, and we wired the LCX with the run-through floppy wire. But next, the thing that developed more tough, that run-through and floppy and pilot was not going to the LAD with the help of the microcatheter. The third picture, you showed that there is 99 almost subtotal occlusion of the ostial left main, ostial LAD with a junk of calcium in the origin of the LAD. The microcatheter was then placed in the junction of the left main to the ostial LAD. Pilot 50 was removed, and ultimate bros 3. This is the stiffer hydrophilic catheter with a tip of 40-gram force. And finally, we succeeded. Finally, we succeeded to cross the LAD with the stiffer wire. Then we pushed the microcatheter and changed into run-through floppy wire into the LAD. Then we crossed the FZ microcatheter, crossed the ostial LAD. Then we did a 2.5 10 NC scrolling balloon pre-dilatation in the left main to LAD and left main to LCX. After first pre-dilatation, this shows like this, and I think that the pre-dilatation was not enough, and I did a pre-dilatation with 3.5 10 millimeter NC scoring balloon. And then I put a positioning the stent of 4 into 18 discs in the ostial left main to LAD. And the stent is deployed at 14 atmosphere. And after stenting the LAD, the ostial LCX, there was a lesion, and previously was that. The wire in the LCX was removed, and pot was done with 4.58 millimeter at 16 atmosphere. Then pull the balloon, and osteoproximal pot was done with 4.5 and 8 millimeter. Rewiring of the LCX to the stent stars were done. And at this was the there was residual stenosis in the LCX, so I decided to do an balloon assisted tap for this patient, older patient. I taken a drug-eluting stent to the LCX 3.5 into 8 and a balloon in the left main to LAD. And for proper positioning of the stent, left main to LAD balloon was inflated to 4 atmosphere, and the LCX stent was pulled back and inflated to 8 atmosphere. So the ostium of the LCX does not miss. In TAP, this is the important issues, or doesn't missing the ostial LCX. So then I deflated the LAD balloon, and LCX stent was inflated to 16 atmosphere, and pulled back the LCX balloon to the left main and gone up to 18 atmosphere. And I do a sequential balloon dilatation on the ostial LCX and LAD was done with the Filin kissing. and the report was done with an 4.8 into NC balloon. This was the final result. I took an stand base. The stand base, you can properly evaluate the stand base. The osteal L6 was not missing. Only one stud or even a simple stud was present in the osteal. So I was satisfied with this. Take-home message was that intervention in doing an left main bifurcation involving the osteal LAD and osteal L6 are always challenging. The tap technique always allows complete coverage of the carina with one single start, and the crossing the LAD with a hardware and crossing the microcatheter through the left main to LAD, and then dilatation of the left main with the scoring balloon was the main important point in this patient. So final kissing was mandatory when treating the left main bifurcation lesion with a double stent strategy. Thank you all for patient sharing.
Questions, discussion from the audience and from our panel of experts.
Thank you very much. I think so. That's a really great case, and your RCA is not tightly diseased.
Not proximal, but seems to be that. But
seems to 50%.
50 to 60%, sir.
Now, thing is that there is a tight lesion in the L6, and L6 is reasonably very good size, and LAD also osteum is also diseased. Why not start with the two-stent strategy in this case? Though the patient is 80 years,
Sir,
why you did not mind your set? Whatever strategy you do it, but why not you set your mind that we need such come the cases, a two-stent strategy I have set up in my mind. But you have to change your mind later on that you think that only the one stent may be the possible because patient 80 years. And also then lastly, you have finished by two-stent strategy.
Sir,
in this case, it is better to start the two-stent strategy. What do you think? Your tap technique is good. And in that case, you can do it, but L6 is reasonably big size vessel.
Sir, I was a bit alarmed with this patient as because the patient was a scheduled CAG patient, coming to my outdoor for several times. I was on optimized medical therapy. He was admitted in our normal ward, and last night he admitted in the shifted from the left normal ward to the post-CCU. And after doing the angiogram, you can see, sir, I did the RCA first, and I was thinking that this will be how it will be a left main, tight left main stenosis, or will be a critical triple vessel disease with ECG finding and the patient having 80 years octogenarian, having comorbidities, creatinine is high. So first of all, if I do the double stent strategy, I will go for TAP. I will go for decay crash or culotte. But in decay crash or culotte, the procedure will be lengthy for me. And the patient was having, before doing the case, I did it ad hoc, sir. And I put, after doing the CAG, I was starting integrin bolus. I gave 4 ml.
No, that's fine. What your strategy is, I am 100% with that.
Sir, I was thinking that.
Thinking is that you can have and putting a stent from the left main to the L6. L6 is a reasonably good size. And there is a 90-degree angle of the LAD. And finish by LAD by putting one stent. Then you will take less time and less, I think so, adrenal secretion.
Sir, I think so, sir. The culotte or decay crash, double wiring must be done. Double stent strategy must be in this case.
Now, why not double stent strategy? Why not putting one stent from the L6 LAD, then putting an LAD stent, sir, and by covering the osteum? What do you think about that?
Consider, I think Devanda is trying to do the procedure very simple and less costly. So he choose the dynamic positional stenting. If needed upfront two-stent strategy, we will add. You already have adopted. It is
because if I go for two-stent strategy, I must go for decay crash or culotte.
But you think positional stenting is okay or not? When you see that there is pinching,
not okay, so and
not okay, then you go to upfront strategy.
Dr. Dhiman, ultimately you have done very nicely. That's very good. Actually, you did the case in ACS status. In ACS status, patient was bad. patient was not stable. Hemodynamic was not stable, and patient had initially you had planned for to stent a left main to
LAD,
LCX,
yes.
left main to LCX, but you said that you had a plan to
No,
stent
I've told that I'll do the left main to LAD.
left main to LAD.
Yes.
But I don't know. You told left main to LCX.
No,
You
sir.
wrongly
Hey,
said that.
That was a
mistakenly.
mistake. That was a mistake.
Because
Okay.
Left main to LAD.
Yes. That was
Left main
mistake.
to LAD.
So now we have to go to the next case, and after that, maybe we'll try.
Yes. Huh?
At least time maintain good.
Yes.
So I would request Dr. Mohsin Ahmed to come and tell
No,
us about ultra low contrast PCI.
I was planning for left main to LAD.
Now we need to talk offline. You all get hold of Professor Dhiman and ask him as many questions as you want.
It is a T20 match, only 7 minutes. Please also show the stop. Okay, now we start. Good evening, lots of faculties and participants here. Everybody, good evening. My case is ultra low contrast PCI. We know we are fighting for the patients of the CKD or going to be CKD, contrast-induced acute coronary injury. We know everybody the definitions of contrast-induced acute injury. Serum creatinine more than 0.3 milligram per DL within 48 hours or increase 50% within 7 days. It is included recent guideline. We know lots of mechanisms of pathology of CI-AKI. So we know some risk factor. Moheran contrast-induced nephropathy risk score is the most acceptable popular risk factor. So how you prevent the contrast-induced acute kidney injury? Number one is the intravenous hydration. It is the most important. Hydration is the most important. Then protein statin, stop nephrotoxic drug, and we use the imaging. This IVAS FFR. Also device-induced intervention, that is renal guard impeller device. Also some contrast sparing strategy and coronary series aspiration and lots of on and radial route can use a nice low and low contrast media. And so you know everybody for the pre-procedure management is the big issue is hydration is the only solution. You should hydrate the patient. How will you hydrate? It is the most important. Hydration is the normal saline. What do we use the rate of the hydrations and duration hydration? Is what is the study? So the poison study, it shows that we giving the normal saline before procedure 3 ml per kg per hour. But if you do the LB-EDP before coronary angiograms, it gives the more precise hydration. That is, if you do the LB-EDP, if it is less than 13, you give the 5 milligram per kg per hour. If it is 13 to 18, 3 ml per kg per hour. If more than 18, given the 1 per ml. So you can measure in lab by the LB-EDP in the hydrations. Hydrations by the LB-EDP measure can reduce the risk less than 59%. And protein statin, you give the statin, rosuvastatin is the choice because the study shows give the rosuvastatin for 2 days before the procedures. After 3 days, also rosuvastatin increase the and N-acetylcysteine. More studies shows cysteine is not now accepted in the real world scenario. So our study is the ultra low contrast PCI is the most important solutions. We know I show the case how we'll do the cases. My case is show it is the patients the CKD patients, female patients come to me with the CCS class 3 angina. That is patient is ongoing chest pain. He cannot walk to the toilet also. His EGFR is 34 ml per minute. She going to the door-to-door intervention cardiologist. Everybody refuse the cases and come to us. His angiogram shows his serum creatinine is 2.7, EGFR 34. Angiogram shows there is the LCX is the tight stenosis LCX. You know always LCX OM is the most painful vessels. So there is bifurcation lesions, Medina 1-1 classifications. So we plan for ultra contrast PCI, that is zero contrast PCI. We hydrate the patients by the 3 ml per kg per hour, then on the procedural 1 milligram per kg per hour, and post-procedural 1 ml 5 milligram per kg for 4 hours, and give it the statin, rosuvastatin 20 milligrams 2 days before and 3 days after the procedure, and acetylcysteine 60 milligram, 600 milligram twice daily for 2 days. Then you show we wiring the two vessels, that is LED, LCX, and OM vessels. The angiogram is not done. It is the angiogram view. If, as the catheter is not the same catheter, so you sided the CA view and plotted the vessels. Then do the IVAS. Do the IVAS, the LCX and OM, and IVAS found you show in the LCX there is the LCX MLA in the proximal part not so much tight, but LCX distal and mid part is the tight area is the 1.47, 1.75. For LCX is more stenotic lesions. Then IVAS, do the IVAS of the OM. OM is not, plaque burden is not so much. It is only 42%. OM diameter is less than 2. So OM is not significant. Also diameter is less than 4 to 2 millimeter vessels. So we're planning for proportional extending to the LCX. Pilation by the 1.5 into 10 and 2 into 10 millimeter balloon. After ballooning, we sizing the stents. How we sizing the stents? From the wire marking from the LED to the OM and to the distal part of the LCX. We found it is the stent sizing by the IVAS correlation. You see, from the LED to OM, 16 millimeter, and OM to distal LCX is the 15 millimeter. The total size is 32 millimeter. So we can get out from this by the correlation process. Then we are stenting the vessels LCX 2.25 into 32 millimeter DS, inflations and stenting done. And after stenting, we do the IVAS. IVAS show there is a stent is expanded in the proximal part, but ostium is not expanded. We are again post-dilation, and it is good result from the LED. And port will be done. After port, we did the IVAS. In the OM is good enough. So we did the OM. You see OM, it is good. Final IVAS shows the LCX proximal is the adequately expanded, LCX mid expanded, LC distal also nicely expanded. Final results. I think we are happy with the final results. We only use the 9 ml of dye. Why? For the observing the dissections, slow flow or no flow, or side-burst occlusions. Also, for the evidence of the patients as a legal issue for the patients only giving the 9 ml of dye. So my take-home message, we found that after 3 days, serum creatinine is 2.1, before was 2.7, because we meticulously, our team managed the patients for 3 days, serum creatinine is reduced 2.1 after 3 days. Take-home message, ultra-low contrast procedure can be performed electrically advanced CKD, engagement of guide catheter and observed advanced guide wire into the coronary artery without using the contrast. IVAS guided PCI can reduce the contrast load and perform the co-resistance sizing of the stents. Deploy the stents by the fluoroscopic guidance, use the IVAS measurement, and complete the ultra-low contrast PCI procedure with final angiography using the minimal contrast. Thank you, everybody. Please save the date. Our conference, IBDR CardioCon 2023, 1st and 2nd May. Thank you, everybody.
3 minutes of question answer, please. Because we have quite a few cases and also we want to see the results of our life.
No, thank you very much. That's a great case. Actually, everybody knows that dye is the most culprit for the CKD patient during the angiogram. And definitely the limit of the dye is important. Hydration is only important. Other thing is that if you can limit the dye, either less injection or imaging, then it is a good choice. And this is a very, very innovative technique that the zero contrast means no contrast, but that meaning is that ultra low contrast, minimum contrast. So I have some experience with these cases. Main thing is that you have to think about the heart, full structure, and you can make the coronary arteries as a wire by giving the wires. Whatever the difference should be in the wire, that's most important. That is got the skeleton of the heart by making a wire inside the coronary. This is the first. Number 2 is that the imaging. We have to measure competent with the imaging, and these are the 2 things is most important, because we have to very much expert with the imaging and interpretation. Then I think so this procedure is very not very difficult, but definitely this is a little time consuming, and you need an IVAS, and that's all. And thank you very much. I think that's a good case.
So any other questions or comments from the audience or from?
Basically, it's a dye which is important. Rosustatin and acetylcysteine, what we talk about, or hydration is okay. But I think that during the lab, what dye amount you use is most important in the CKD.
Thank you for a nice presentation. Thing is that this is sort of, I mean, in our perspective of our country, this is difficult because of, you have to have IVAS, and you have to be very good in IVAS imaging. You have to decide from IVAS imaging. This is one problem. And if there is a diffuse disease and calcified, you cannot pass the probe of the. That is a difficult. That is a limitation of the procedure. You cannot go in the very difficult cases. You cannot go, because if the probe doesn't go, the whole procedure will not be possible. So this is for limited cases, and in centers where IVAS is commonly used, and the doctors are well adversed with the IVAS. In that case, this is good. And in some cases we can do, but this sort of I should say in limited cases. Because we have diffuse disease, very calcified, you cannot pass the probe of the IVAS. So where can you do in a different techniques?
No, I think not so, because if you for IVAS, for rota, not needing so much dye. If you want to expert on it, you have the IVAS, you can challenge any difficult cases. Dr. Manik, you can experience it so.
Basically, what he's saying that if IVAS is not there, what we can do? I think you can put a 2 wires, define the distal point, define the proximal point, and dilate it. Lesion preparation is good. Without dye, you can put a stent there. With that visual impression and your experience will help you in deciding the stent length and how do you prepare the bed. That's very important.
You cannot rota cannot use the
You can use 2 wires where the wire at a distal point you can put it verbally and then choose the stent size. Without IVAS, you can do that procedure then.
And finally, you come with some small amount of dye.
Without
So you try to basically you try to imaging and you can use a diluted dye, 50% saline and 50% dye. That's the one thing which you can reduce the dye. Second is if you don't have IVAS, wire can be used to mark the points proximal and distal, and then prepare the lesion and put a stent.
So we should not do the IVAS, because IVAS is the most important to hygiene the stent, because if miss the one lesion, it is a disaster of the patients. So should use the IVAS.
No dye technique. I think imaging becomes very important instrument, but if it is not there, these are the 2-3 things which we can do.
So we have to go to the great case, great discussion. Now we move to our third case presented by Professor Liaquat Ali from ICRI. Again, 7 minutes and then 3 minutes discussion. So we are trying to keep on time.
Good evening. Assalamu alaikum. I think my case is a very simple one for this international conference. So I apologize for that.
Modest, but thank you for coming, and we appreciate whatever you're
because of the cases I have seen, we are accustomed to that. But my case is very simple, and it will be helpful for the beginners. So I am presenting my case. So I will discuss the case. It is a gentleman of 60. He has hypertension, he has diabetes, and he has chronic stable angina. He is hemodynamically stable, ECG normal, echo normal. And clinically he was sound. So he came for elective angiogram. And even the angiogram you see that the LCX has significant bifurcation lesion involving the OM1 and the big LCX. And also the second OM also has disease. And all other vessels are nearly normal. So regarding the assessment of the bifurcation lesion, that Medina 1, everyone is knows, but in my case, it was Medina 111. But Medina does not give so much information regarding the vessels, because what is inside the vessel, is there any calcification, and other qualities which are included in the complex bifurcation is not reflected by the Medina classification. So there is a guideline, which is definition study, which classifies which is complex, which is not complex. So in case of left brainstem disease, when the side branch has more than 70% stenosis and the length of the lesion is more than 10, it is one of the major criteria for complexity. And if it is a non-elimination, then if the side branch disease is 90% or more, and the length is more than 10 or 10 millimeter, it is one of the major criteria for the non-LM bifurcation. And among the minor, there is a moderate to severe calcification, multiple lesions, active thrombus, bifurcation level less than 45, and the main branch diameter is less than 2.5, and the main branch lesion is more than 25 millimeter. So these are the minor criteria. So when a case has one major criteria and two minor criteria, it becomes complex. So in my case, I have calculated it is in between. It is not a complex, it is not a simple one. So it is in the intermediate position. So what to do in my case? That I have seen that I have two obtuse marginals are involved, and I am confident that I must have to save one of the OM. So regarding the lesion extent of the narrowing and the position of the lesion, I decided from the outset that I have to do two-stent bifurcation stenting. And if you are going for two-stent bifurcation lesion, then you have to think for the angle of the lesion. In my case, it was less than 75, it was around 45. So my option was crash, to have use any one of the crash techniques. And nowadays, most of the people like the decay crash, so I decided for the decay crash. And what about the comment of the panels? I don't know. Do you like we proceed with the decay crash? Okay, thank you. So these are the steps of the decay crash. You know, all of us know about it. So this is my case. So the two Sheehan blue wires are passed in the OM and the circumflex, and use the EBU catheter 3.5, and it is transradial. So I first put the stent in the OM1, and it was 2.520, and I have put the stent inside the main vessel about 1 millimeter and deployed the stent. After deployment, I found it looks to be good, and there is a balloon in before doing the deployment of the stent in the left main vessel, and I pulled it up, and I have crushed the lesion. Then I recrossed the OM1 and also advanced one balloon for the first kissing. And we are proceeding for the first kiss. And we did the kiss nicely. So after this, I have seen there is something wrong in the main vessel. There is staining, there is dissection in the main vessel. So nothing to worry, because I have to take a bit longer stent. And I deployed the main vessel stent. Then I did the first port. I used the 3.5 10 millimeter non-compliant balloon. Then it is the second keys. And this is the second port. This is the final result.
I think so. This is really.
No, I have
great
something
job.
to say more. So in my case, it is take-home message that it is sometimes challenging when the lesion is close to the left main. So in my patient, the lesion was very close to the left main because it was difficult to accommodate 8 mm balloon for the pot. So I was a bit worried about that. And sometimes the rewiring is challenging for some time. And otherwise, we have to think always, or we have to look for the complications as I have in this patient, this dissection. So before deployment of the stent, we looked for it and everything went nice. Thank you.
Thank you very much. Thank you, Liaquat. You have nicely tackled that. But what is my? Okay, we want to go to a cath lab.
So would you like to show us the last of the what happened, what you did?
Yes, yeah. Thank you very much, Dr. Malika. So let's go forward. We have done IVL. We delivered all those 80 pulses, and we got a very good.
You want to see the angio views, huh?
Yeah. So you're going forward, and so this is after delivering IVL, we were able to advance this 3048 synergy very smoothly. It went very easily. Did not need any push or anything like that. So that was a good advantage of doing both the rota and the shockwave. So then we did a 3.5 into 24 synergy proximally, making sure that there's overlap with the stent boost in several views. And then, as you can see, we post-dilated there with the stent balloon and also a 3.5 NC balloons, and got definitely a better result. And there's always some distal spasm that we gave nitro, and this is a final angio. But let me show you the next picture as well. Proximally, it looks like that there's a lesion in that ostial LAD, but it measured on the IVUS at 7.8, I think.
7.9.
7.9 square millimeters. So I did not want to cross with another stent then if it is not really indicated. So this is the end of the angio, but we can show the IVUS, the final IVUS run. Can you see the IVUS?
No, we can't see the IVUS.
IVUS, please. IVUS, Rana. Dr. Tofik.
So
IVUS, please.
We want to see the IVUS.
Yeah.
So yeah, angiography looks great, but there was a question from the panel that should we, as there's some disease in the ostia, why don't we take a stent from the left main to the
Dominant
LAD?
L6.
So if you had taken a longer stent and deliberately deployed it from the left main to the LAD, at least your angiographically, I suppose, it would have looked, the proximal LAD would have looked better, right?
That's true. That definitely. But
he explained that on IVUS, the IVUS LAD ostium is reasonably good, and the MLD was 7.5. That's right.
7.9.
Yeah, minimal lumen area was 7.9. Huh?
7.9. 7.9. So it is reasonable that we can give up the LAD ostium stenting.
Yeah,
we can lift it.
Now,
but
actually,
definitely somebody in favor. But I'm not sure.
But
we need more aggressive lipid lowering.
Yes. So circumflex is a big and dominant artery. So in these circumstances, if we go from the left main to LAD, then there may be question regarding circumflex. What to do?
That's a very important learning point that we need to remember. If you have a dominant circ, you really need to be very careful about it. And another thing about intervention is that we are not here to do, plastic surgery or this. We're here to open up vessels, right?
Yes.
And if you're, he found that the MLA was very adequate. So even though angiographically it doesn't look that nice, but the result is excellent, right?
Ma'am, can you see the
And
IVUS?
on the other hand, the world is moving. That less number of the stents is more found.
Can you put the IVUS? So this is the indirect image of the IVUS from the camera only on the screen.
So the distal edge, there's no dissection, and the minimal lumen area is more than 6 square millimeters. And there's definitely calcified nodule. You can even still see here in the at the 10 o'clock position. So that's why I think with the orbital atherectomy or IVL is a way to treat these calcified nodules. And with IVL, we are definitely able to get a better stent apposition and expansion. So it's well opposed, no issues in dissection, and we're coming to proximal. That's the proximal lumen area that measured at 7.9. Yes, there is a plaque all the way from 12 o'clock down to 4 o'clock or so. There's a significant amount of plaque burden. But I feel that we need to act not based on the plaque burden, but at least on the lumen area. So that's the distal edge.
Yes, thank you, Ramesh.
Thank you. Sir.
Thank you. It is a great job. I think so.
Yes. Sir. Thank you very much. This is, I think, our first demonstration of.
Thank you. Thank you for demonstrating a lot of learning points to us. That was a very difficult and complex case that you dealt with very elegantly. Thank you to the entire team. Thank you. So so please, we are back with.
Okay. So, Professor Liakut, I have a small comment. You have an L6, that is big size vessel, and 2 OM.
Yes.
One after. I mean, 2
Yes.
OM ostium is also disease.
Yes.
So why not put one stent simply in the LCX and putting a ballooning or drug-coated ballooning in the 2 OM? Now world is moving, less number of the metal than more number of metal. Why did not you do that? Because in the L-shaped ostium, you put a double barrel. That is, though it is a minimum overhanging, I know that you have done a decay crash, that is nano decay crash or minimum prolapsing in the LCX. But still there is chance of the LCX ostium origin stenosis. If it has happened, then it is very difficult to tackle it. And why not very simple, one stent and ballooning of the 2 OM, because you give up the 1 OM either. You did not tackle the second OM. Only you tackle the first OM. First OM and second OM equal size.
Almost.
My question is almost equal size. My question is that simply putting one stent and ballooning the OM and finish it by drug-coated balloon. What do you think?
So I could balloon the second OM before stenting the main vessel. But putting 3 wire through 6 French guide catheter through transradial is a bit difficult. So I ignored the second OM, and I believe if I lose it, I have a protection from the proximal OM. But fortunately, it was saved.
Great, thank you. So, thank you. We
Okay,
can move to
thank
our
you.
next case. Thank you so much. Now we have Dr. Ahmed. No, we don't have. We have Professor Mir Nesaruddin Ahmed from Heart Foundation. Seven minutes and then 3 minutes. And your time starts now.
Honorable Chairperson, distinguished panelists and moderators, and audience, dear audience. Sometimes simple case may turn into complex one. And the case was very simple, but they can turn into complex one, and it was totally off-level work, I think so. So my title of the case is an approach to optimistic solution. A patient history was 37-year-old, he was migrant worker. He was presented with class 3 angina. He had history of entry MI with previous history of PCI to OM in Saudi Arabia 2 years back. And the echo revealed 30% ejection fraction. And this his coronary shows this is a left main 56% stent at the shaft starting from its ostium, and LED 80 to 85% the proximal segment, and L6 totally occluded in its distal segment, and good size OM free of disease with stent patent. And RCA is free of significant disease. And this is the left main and RCA. And left main to LED wired with floppy wire, another floppy wire placed in the aorta for and 3 to 38 millimeters this stent was placed across the left main to LED, and stent position and deployed. Stent balloon slightly pulled back and went on high pressure. Post dilation done accordingly, and then port with higher balloon. After port, floor image showed 10 to 12 millimeter proximal part of the stent is back out in the aorta, and accidentally wire also came out, and that was the scenario start. Trying to rewire, and finally rewire done with floppy wire. Then again post dilation done with 3.5 to 15 NC balloon at high pressure, and port done and stent start crushed by same balloon. Image after stent start crushed, report done with higher balloon, NC balloon. They are now show the crushed portion of the stent is hanging in the left main. So what to do now? Now try to retrieve the crushed portion of the stent by wire twisting method. And we tried for several and ultimately catch out the stent and totally removed. After several attempts, then ultimately become successful to catch this crushed portion. But problem is that the target was retrieving the crushed portion of the stent, but whole length of the stent come back. So image after retrieving the stent, LED is okay. Then again we plan to add another stent 3 to 5 38 millimeters positioned the same across the left main to LED, and stent deployed, and stent balloon pulled back and going to high pressure, and port report done. Then post dilation again with the NC balloon. This is the final result. Patient is doing well, and it has been confirmed with the subsequent follow-up. And the stent dislodgement is only very rare case, particularly inflated stent. It has incidence was 0.3 to 8%. And a few cases of the expanded stent dislodgement has been reported in the literature. And what the mechanism? Retraction of the inflammatory balloon quickly with maximum force without checking the deflating balloon might result in the trapping, and sometimes the underestimation of the vessel size and for stenting of the proximal lesion rather than distal. And stenting may trigger acute vasoconstrictor by its effect on microvascular endothelium and may result in use of the smaller size stent. Stent retrieving can be done percutaneously or surgically, but percutaneously can be done if the patient remains stable. So several retrieval methods are defined, including biliary forceps, twisted guide, multipurpose basket catheter snare, modified snare, small balloon technique. Our most prepared method is small balloon technique for unexpanded stent, and has success rate of around 70%. However, the dislodgement of the fully expanded stent is very rare and has a high potential to cause catastrophic events. And it has shown that complete deployment stent was successfully removed with the twisted wire method in few cases. Retrieval method in fully expanded stent have some limitation. So complication may arise, and it may deal with the emergency of coronary artery bypass surgery, or may turn into acute myocardial infarction, or may stent may embolize. So most of the previous reported stent dislodgement case have occurred before the complete expansion of the stent in the target vessel, and it's most impossible to remove the fully expanded stent. In summary, coronary angioplasty has been supported by the stenting because of reducing the risk of revascularization and restenosis. PCI has become a widespread and effective modality of treatment, and procedural complication can still develop. So stent dislodgement is rare but serious complications, so extra care should be taken. And the strategy used to deal with this complication may differ among the patients. Therefore, the use of different equipment for several techniques can be combined for various scenarios. And thank you all.
Difficult case, right? Successfully completed. Congratulations. But we have
No.
Pardon, sir?
Part of the stent fracture.
Yes, sir.
But it is connected with the main.
Yeah, total stent, sir. When I just hook the cast portion, whole stent come back. Total, just single wire.
No. Thing is that the stent was, you retrieved the stent totally, or some part of the stent remaining in the.
Total stent. As because the IBUS is not there in that situation. That's why I present this case. That's why, and only two case probably one is a Turkish paper and other is Egyptian paper. I found it.
And also if
very
you
rare
think
situation. I have seen the 0.2.
how this small connection, this thing, has got the traction force to bring the whole length of the stent.
Whole stent, yes, sir.
It is.
Please, sir, thank you very much. Sir, stent doesn't come after expansion, after getting very strongly placed in the blood vessel. It comes when you inflate it. During inflation, there is a force. It can come, towards the, proximally. And it actually, after you inflate, you see that part of the stent hanging. I have seen a case hanging, proximal to the left main. It doesn't come. It will never come once it is placed strongly, and it is very difficult
But
to retrieve.
here it expanded.
And if it is an undersized stent and balloon, if it is an undersized
It is
stent,
not undersized. There was 3 millimeter. 3.5.
and undersized to the left, say in cases where it is undersized and you have inflated, you have not deflated the balloon, you have not properly deflated the balloon, and you pull it, it will definitely come.
It's a very rare 0.5. Very rare.
It will come before you at the time of inflation.
Yes, there is a chance.
Underinflated balloon.
There is a chance of displacement because if the patient take a deep breath, then stent can
Yes,
come up.
of course.
But once you expand,
Was it stent got elongated? You want to say?
If the stent is
got
not
elongated
properly
in the
deployed,
There comes all the it's a single.
Dr. Mizan, the new EBC 16 new concept, new documents paper 2 is strictly said that the new generation stent, the old thought is obliterated. Before we know that if we postdilate, it is elongated. But now the consensus is 1 millimeter diameter extension, it reduces the foreshortening the 2.2 millimeter, 2.20 millimeter. Shortening. I don't know which type of stent he used, but post-dilatation reduce. For post-dilatation, it is new generation stent. After post-dilatation, it become foreshortening in a rate of 1 millimeter, increased 2.2 millimeter.
Amal, situation is not the foreshortening. It is different issue. Only the Victor stent or the Kamal Raju stent. These two stent is a single thread stent.
Single cardiac stent.
That can come out. But how come this laser
hold
cut
on.
tubular stent come out? It is not clear.
এটা তো বুঝতেছে না স্যার স্টেন্টের কি কিছু পোরশন ভেঙে গেছিল তুমি বার করতে গেলে কেন
Stent was hanging in the aorta 10 to 12
না বার তো করতে হবে।
That's why I'm
The stent was there and the
part of the stent,
no.
about 10 to 12 millimeter stent is hanging in the aorta. What should I do?
So I think this is a never-ending story of what he did or did not do. Yeah, so
Okay,
the
sir.
thing is, we will talk about it offline. We are
That's why I'm
really,
talking is
really-
offline work. This is not online work. As because I don't have any IBUS. If I did IBUS, then it could
But
be.
you see, you're, I mean, there.
And that's a matter of.
But one question.
Now, in that case, I
Don't
can show the
practice this
vessel, and whether the stent remaining part of the stent is there in the vessel or not. That could be seen in the through the IBUS. Otherwise,
No, sir. But don't practice these things. There is nothing to be learned from this slide. But one thing, even if some part of the stent remain hanging in the aorta, nothing will happen. Leave it like this. Simply.
Yes, we have an experience, sir. Just leave it. Just leave it.
Okay, thank
but
you.
only
Nessa.
few cases, sir. Only few cases I have seen
Thank
in
you,
the
Nessa.
net.
Right.
Thank you,
At
sir.
least you retrieved it. Now we would ask Professor G.M. Mokbul Hussain from Ibn Sina to present his case. And actually, Sabina, you'll be concluding our NHF 2022.
Assalamu alaikum. The previous all cases are stenosis or occlusion, but this case is something different. It is not stenosis or occlusion, rather it's a big aneurysm here. So here aortouniiliac endograft with fem-fem crossover bypass for abdominal aortic aneurysm. This is a modified hybrid approach. Here the patient aged about 85 years, hypertensive, non-smoker, non-diabetic, having a pulsatile swelling in abdomen for 1 year. Duplex study revealed abdominal aortic aneurysm, and CT angiogram showed secular abdominal aortic aneurysm having diameter 8 centimeter. This is the CT angiogram picture showing a huge secular aneurysm at the lower part of the abdominal aorta. So treatment in cath lab, the aortouniiliac endograft was deployed, and under epidural anesthesia, approach was left and right common femoral artery, that is the percutaneous approach. So the hardware used, this is aortouniiliac endograft. This is iliac limb endograft. This is concerto detachable coil. This is the Landerquist stiff wire. This is 18 French vascular access sheath. This is the compliant balloon. And this is the PTFE graft which was used for crossover bypass. Here we can see this is there is a secular aneurysm, and deployment of the aortouniiliac endograft started. Continuing the deployment, and we can see the endograft is being deployed. Angiogram shows still there is the sac just distal to the deployment continuing, and this is the end part of the aortoiliac endograft. There is sac at the distal part of the endograft. So another extension, iliac endograft was deployed, and there was an overlapping. And this is the combination of two, that is overlapped. One is the aortouniiliac and another is the iliac portion. And there is no leak through the junction. Angiogram via right common femoral artery showed there is retrograde leak. So coiling of the right common iliac artery was done with concerto coil. Picture showed apparently occluded right common iliac artery by coil. So this is the completion angiogram and coil in right common iliac artery. Then patient taken in the operation theater, crossover fem-fem bypass from left to right done using PTFE graft. Post-operative room, still pulsation in abdomen, and there was thrill bruit. Duplex study revealed there is retrograde leak in secular aneurysm from via right common iliac artery. There is the coil failure. So plan was to ligation of right distal external iliac artery. So patient was taken in the OT second time, and ligation of the right distal external iliac artery was done. We can see in the picture. And now no pulsation in abdomen, no thrill bruit. Patient was discharged on 5th POD. Follow-up after 1 month, no pulsation, no thrill bruit. This is the follow-up X-ray. This is duplex study and patent graft with thrombus within the sac. So learning vascular plaque is ideal to occlude big artery like common iliac artery, but we had no vascular plaque at that time. Critical analysis of aneurysm, bifurcated endograft could be used in this case with percutaneous technique. So aneurysm treatment is different from stenosis or occlusion regarding hardware, stent, as well as cost also. Aneurysm devices are costly. Procedure needs precise and accurate measurement of A to Z of aneurysm. Technical efficiency and learning curve are also factors. Thank you all.
Thank you. So questions, please, for 3 minutes. And then we'll have our last case.
মকবুলের সুবিধা মকবুল দুইটাই পারে যে কারণে সে why you have not choose the Y graft here?
Patient 85 years old.
Whatever it is, you have done surgery twice.
But Y graft needs midline long incision, big
No.
laparotomy.
I have done that one. Sub renal secular aneurysm extend to both ileum.
But we have to go for laparotomy is needed. Without Y graft.
Why graft laparotomy needed?
You have to aorta biforal.
The device you have shown 3M. The aorta and 2M.
You're telling about EVAR or not Y graft? I'm confusing.
You are talking about
aorta uniiliac endograft. You are talking about Y graft.
Aorta ilia. Oh, I see. It was a single side.
Single
sorry.
side. Single side.
I thought it is the both ilia.
No. Single side. So crossover bypass was done.
So because you have got
But this
experience of
crossover
both
bypass
ways, that's
from
why you
groin
could
to groin,
manage.
no laparotomy was needed here. This is less invasive than midline laparotomy.
Congratulations, a good idea.
Congratulations on a very difficult case. First didn't understand what was going on, but thank you. Right, great case. And now, if there are no questions, we'll go to our last case of this year. Sabina Hashim, Professor Sabina Hashim of NICVD.
And good evening. Assalamu alaikum. Today my case. Sequence of unpredicted events while dealing with calcified coronary artery lesion. Our experience. A 70 years old hypertensive non-diabetic smoker, gentleman with recurrent chest pain on minimal exertion for last 2 months. ECG showed anterior ischemia. Echo was normal and coronary angiogram was done. There was severe calcified lesion in LAD and RCA was normal. He was sent to our institute for better management. So for that, we started our procedure with the right distal radial axis. Here we used the 7F slender sheets, that is 7 in 6, and 7 French guide catheter. So we took the guide, 7 French guide, tracked with the Cumber technique. And this was the left system. Diffuse stenosis with calcification of the proximal to mid LAD. So we thought that we'll do upfront rota. So rota ablation, we choose the rota ablation, and for that we use the floppy wire with micro catheters to cross the lesion, and then it replaced with the rota wire. And rota was done first with the 1.25, then with 1.5. After that, we took the IVAS. So there was 360 nearby 280, 360 calcification. And there was also a dissection. So the left main, the left main was normal, MLA was quite good. Then left LAD ostia, it was also good. Then the mid LAD, it was quite low, 4.1 MLA. And there is the dissection we can detect from the IVAS. And this is the distal LAD. So we started doing pre-dilated with the NC balloons, 2.5, 12. So we took a shot. So see, there is no slow flow or no reflow phenomena, I think, with that dissection. So we again dilated and see balloon 2.75 and then scoring 3 millimeter. Then we deployed the stent, distal stent, which was 2.75, 26 millimeter. But for proximal part, for proximal stent, it was not, so it was, we were unable to deploy it. So we think of using body wears. So here we deployed the proximal stent that was 3x38, overlapping with the previous one. So after deployment of the stent, so we just tried to pull out the wear, but it was very tight. Though we managed to remove the wear, so this was the scenario. We took the stent boost. So what was it? So it was stent migration or stent recoil. So jail wear was no jail behind the proximal stent, but it was in the middle of the distal stent. So whenever we tried to pull it, so it was torn down, the distal part of the wear, and also with it, it pulled the proximal stent up. So again, we dilate with scoring balloons and NC balloons. And then we put another stent in the middle and jailing the torn wear with the wall and the stent. Post dilatation done. So this is the final scene. So we all know that these are the treating for coronaries. We won't go through that. The severity of the calcification, we all know that. And here the complications was decreased anti-gate flow by dissection. Some trials there. So now learning point, the calcified coronary arteries are common yet unpredictable problem. Vessel calcification may cause difficulties in intervention, like using the unable to deploy the stent or track the stent, or it might happen malapposition of the stent, and drug might not reduce drug from the drug-eluting stents, and sometimes stent might fracture. So use of different plaque modification device in calcified coronary lesions for the stent placement is needed. Imaging modality guide is needed for optimum results. Regarding jail wear, though there is controversies, but it should be removed after stent expansion by nominal pressure, especially in calcified lesions. Complication will happen if you do intervention, but bail out from the situation is the most important one. So above all, work as a team. So together, everyone achieves more. Thank you. Thank you for.
Thank you very much. Thank you, Ashram. It is a really great case and nicely done. And you demonstrate the rota and complication. But I have a small query to you, because there is a fellow here, there is a mid-level doctor, a senior doctor here. Why not do the imaging first, then do the rota? Because you done the rota without imaging. This is first question.
Sir, it was a severe calcification, a Tram-check calcification. We tried to negotiate the IVAS, it didn't go.
No. Thing is that if the calcium, but did you try for that? Did you try for the IVAS?
Yes, but it didn't go.
Why did not you dilate it first and do the IVAS again? You can try for that.
Yes.
Then do the rota.
Yes.
I'm just telling you,
yes.
I'm sure that you have tried all this, but I am recapitulate everybody that ideally imaging should be done earlier. Either it could not be done like the Ramesh case, that's a different issue. But definitely York issue is cases like that. But in regular practice, we have to do the IVAS, then go for the road IVAS and
Yes,
second
that-
point is my point, that is deploy the stent, and you can put the wire in the healthy vessel, but you cannot put the wire between the two metal. Can you follow my point?
Yes.
Because if your gelling wire, if it is in between the metal, then definitely it will not come out. So there is no recommendation that you will keep the gelling wire into metal layer. You can put it into the normal healthy vessel, then you can tackle it easily. But here you keep the wire in the two stent. That's why it is done come out. When it's come out, the stent was deformed, and this is longitudinal effect, and everything is that you have tackled it nicely. Thank you very much.
Yes, that we could do whenever we deploy the stent, we could remove the wear out and then deploy the stent.
She
Yeah.
used it as a body wire.
Yeah.
She could have removed the wire and then deployed the stent.
Yes.
Then
Thank
why
you.
why there is a gap?
Oh, I have shown that. No, whenever we try to pull the wear, it just brought the proximal stent up. So
Why?
there was it was stuck. The wear was stuck. So whenever we tried to pull it out, the stent came up.
Oh, it is the older wire.
No, sir.
Exactly. The wire was entangled with the stent. When she was pulling the wire, the stent was pulled proximally. So there was a gap between the partners.
Very unusual. Thank you very much. I think
Thank
so.
you.
So why not the INUS consider second wire come out? Because maybe
I will consider
you are using the first stent enter the stent start. Maybe one causing through the
No.
Basically,
No.
Maybe because it go to the insect, so cannot come out. So maybe INUS can help you. What the good purpose when.
Okay, no. Okay, discussion will continue later on. I think so. Congratulations, and you have nicely done the case. You tackled
Thank
the
you,
rest.
sir. Thank you. Thank you
But
very much.
you have done very nicely. Thank you very much.
Thank you all. We have just a last formality. So hand over the memento to four of our speakers. So requesting Dr. Mohsin Ahmed, Professor Liaquat Ali, Professor G.M. Makbul Hussain, and Professor Sabina Hashim to come forward and take the memento from our chairpersons and panel. And have a photo.
First of all, we give it to please then.
Professor Liaquat Ali. Professor Makbul Hussain. Professor Sabina Hashim. Now, I would like to request Professor Fazila Malik to say something and conclude the conference.
Well, it's great. After 2 years of COVID, we last had this in 2019, and then in 2021, it was sort of very like semi-virtual, so that wasn't any fun. But this is again doing it the proper way, and it's really nice to see you all. And that's our point that we measure, that how many of us were standing here till then. So thank you. A big hand to all of you who are still here. Thank you. And you are the ones who make our conference successful. And this conference is done for you. And that's why everyone comes here. And it's a great learning experience. At least I have always learned a lot from this conference. And I would like to really thank all our faculty, those who came from far away and those who live nearby. Everyone, a big hand to everyone who supported us, who came here and who were so generous in sharing their knowledge and expertise and wisdom with us. Thank you, and we hope to see you again in the future. Next, we have to thank all of our staff. I mean, you guys made it possible. Everyone, a big hand to everyone. But obviously, the biggest hand goes to Tawfiq and Dolly because they sort of are the bedrock for this conference. But then I have to say Smita, Nazmun, Aki, Ishrat. Okay, so we have this huge big list. Sabir, Ishrat, Kalib, I mean, Rana. Okay, Rana. Who else? Please. Kibriya. Okay, go on saying. Nijer naam bolo, ami bolbo. So we'll be Abdul Qayyum. So everyone, Dhiman, everyone. So please, if we don't mention the names, but everyone, Cath Lab staff, exactly, Morshed, Lipi, everyone, many of you are here, many of you are here, but everyone really worked hard to make this conference a success, and thank you, everyone. I mean, it's impossible to name everyone because we would be here till at least, a month. Next is we have to thank the industry. So do we have a list of that? Could someone show the list, please, so that we could formally acknowledge? Without you guys, it would not be possible to have this conference. So thank you. If we can show the list, it's great. Even if we can't show it, we thank you all. And who else? The last thing. Yes, of course, everyone. From home as well as from far away, and especially those of you who came from far away, we really appreciate your generosity in giving your time and your effort. Thank you so much. Also, now we have the list. So that's those of you who supported us. Thank you so much. A big hand to all of you. And I would like to conclude by saying that we would love to have you again in 2023, 1st and 2nd December. And please, you're all invited to that. Tom was saying that, you give this blanket invitation. I mean, some people do. So that's it. It's a blanket invitation to all of you. Please do come over. And now the last thing we do is we take a photograph of those who were here till the last. And we do it in 3 rows. So one row sits. Those who think they're elderly and are senior, they get to sit. Those who think they are a bit young, they stand here. And those who think they're really young, they stand here. So you have your choice of what age you feel you are. And so today we usually it's a few people today. Actually, it's unusually a bit crowded. So we'll see. No, it has to be a bit front because we have this decoration here. Yeah. So we have lots of people, so we'll have to. Please, this is a group photo that we'll send to all of you, or you can collect it from our hospital. And this is something that we do every year. Once this is done, please, everyone who's in this room, we have to take a photo. And last of all, you're all invited to the dinner.
One more. Okay. Ready, please. Thank you.